Hello, and welcome to Blue Tree Banter, a virtual panel where we sit down with some of the top experts in the industry and get their take on relevant topics in today's healthcare environment. I'm your host, John Price Hamlet, and I manage Blue Tree's inpatient clinical KPI team, where we help organizations implement innovative solutions to drive performance improvement. Today's panel will be focused on cost savings within the acute care space, and I'm excited to be joined today by Dr. Adam Corson and Dr. Steve Beck. During today's panel, we'll review a couple of initiatives these gentlemen have led at Swedish and Mercy Health, respectively, and get their input on how other organizations can implement similar cost-saving strategies at their facilities. Dr. Corson, Dr. Beck, thank you for joining me today. I'd like to go ahead and get started with some introductions, and then we'll get right into the questions. Dr. Corson, would you mind kicking us off here?
Sure, happy to, John. My name is Adam Corson. I'm a practicing hospitalist at Swedish Hospital System in Seattle, Washington. We're a 5-hospital system, and we're affiliated with Providence St. Joseph Health, which has a presence across the West Coast. In addition to my duties as a hospitalist, I serve as the medical director for clinical documentation integrity at Swedish. I'm also the chairman of the P&T committee at Swedish and the co-chair of the system P&T committee at Prov St. Joseph.
Dr. Beck?
Hi, happy to join you today. Stephen Beck. I'm an internist by training, and I currently serve as the Chief Medical Informatics Officer for Blue Tree. I've done a lot of CMIO roles and also play a interim role in a large health system in the Southeast as well. I've had about 20 years of experience with Epic and have continued to participate in quality and safety initiatives, which really speak to what we're going to talk about today.
All right, thank you. So, like I mentioned before, we're going to focus on cost savings today, and it's a big focus everywhere in the industry right now. And with everything going on in the world, there's a lot of places that are strapped for cash, and most are working with razor-thin or even non-existent margins. And I think everybody can agree that we're looking to save money wherever possible. So with that said, what's something you'd suggest organizations focus on right now when they're trying to drive down costs? Dr. Corson, we'll start with you.
Yeah, one area we've really focused on is pharmacy and the inpatient formulary in particular. By reviewing our formulary spend and targeting individual medications, we've been able, at Swedish at least, to save anywhere from $4 to $6 million a year the last 3 years. The way we do this is typically targeting a high-priced medication, reviewing the available literature, talking to the providers using it, and more times than not, we've been able to implement strategies to use the medication in a more cost-efficient way. And more times than not, this is done through Epic, building tools in Epic, kind of builds that guide the provider to guideline-driven use of the pharmaceutical. And we've taken that approach, and now we're expanding it at the PSJH, Prov St. Joseph level, which is a 51-hospital system. This year, we're targeted to save about $15 million across the board. So that has been an area that has bore a lot of fruit from a financial savings point of view.
That sounds pretty impressive, but it also sounds like it might be a pretty heavy lift for an organization to take on. Do you have any words of advice for folks that are looking to take on a similar project?
Well, I will say when we started, it was a little harder than it is more recently. Once you kind of get the hang of it, it hasn't been too bad. And given our experience, we have anywhere from 40 to 60 targets we've worked on over the years. And so we've done a lot of that work. For another hospital to take it on from scratch, I agree with you, could be somewhat of a lift. But I think there may be potential opportunities for partnership between an organization or individuals who are familiar with this landscape and those looking to develop similar strategies to address their pharmacy spend.
Now, I noticed you mentioned incorporating some stuff into the EMR to help out with some of these initiatives. Can you just touch on that a little bit more?
Sure, I'll give you an example. So one target we had is IV iron. So there's a number of IV iron products on the market today, and there's actually a fair bit of guidance, depending on the patient population, on how those should be used in the inpatient space. But I think the run-of-the-mill provider, there's a lot going on if you're a practicing physician these days to be up to speed on all the nuance of the available products and their cost and when they're indicated and when they're not is not really a reasonable expectation. And so we sat down with the kind of relative providers, nephrologists, we talked to the OBGYN group, cardiac surgery, and we developed a pathway in Epic whereby a provider just puts in iron. And from there, the panel that we built in Epic walks them through, depending on the circumstances of the patient's care, to the correct iron product. So for instance, everyone starts with PO replacement. There's good data that shows that PO works just as well as IV, but there are certain circumstances where IV is preferred. And then when it is preferred, we guide those providers to the most cost-effective product we have on the formulary. And it's Swedish, I should mention, using that approach, I think we saved, I think the number was roughly $700,000 a year. And we're currently in the process of expanding those Epic builds across the 51 hospital system of Providence St. Joseph.
Oh, that's really impressive. And I would certainly agree with a lot of that, the concept behind the physician nudge there.
Yes.
We typically see organizations do a lot better and have greater outcomes when they kind of supplement physician education with enhancements to the technology. Usually a pretty good outcome.
Yeah, education alone, while well-meaning, in my experience, it will not get you all the way there. It really helps to have something built in the electronic medical record that serves as a reminder, serves as a guide, and really offloads the providers from having to memorize, all the nuances of, many medications and different clinical scenarios and so on and so forth.
Oh, sure. Dr. Beck, I'll pose a similar question to you. What sort of strategies would you recommend folks take on when they're looking to improve cost savings?
Well, I think, in my view, it's really a three-legged stool. So you really have to start with some form of analytics that allow you to look at what your gaps are, especially your financial gaps. And many health systems may have that. But in the case of pharmaceuticals, for example, what's the largest spend? What's the most expensive drug? And is there a benefit to those particular drugs? We know, for example, that a common pain reliever, when given the IV form, is literally 1,000 times more expensive than the oral form. And does it really work better? So once you start with the data, you can start to make those decisions and then marry that with the other two legs of the stool, which Dr. Corson already pointed out, which are provider education on the one side and then electronic tools on the other. So when I was with Mercy, we did a very similar attack on both opportunities to improve better patient care by reducing cost and consistency of care with regards to pharmaceuticals. But I'll give you a different example that might shine a more basic light on it. We also looked at blood utilization and blood matching, if you will, making sure that the patient gets a blood product when appropriate and they get the right amount of blood. So when I did my training, blood was oftentimes given with 2 units at a time. You'd always start with 2 when you went to transfuse a patient. The reality is that's not the best approach these days. And when we had originally built out our Epic system, we had defaulted with 2 units. And so a simple change was starting with 1 unit and educating the providers on the appropriate selection list of reasons to transfuse, and even transfusion range can immediately have significant impact. So couple that with good analytics of use or potential overuse of product with provider education, you really have a good three-legged stool that will help you get through a good project like this. When we did this at Mercy, our target was to really be appropriately prescribing blood when the patient really needed it, and not overuse of products, which there tends to be a scarcity of, and they're very expensive. So doing all that together actually provides great patient care, reduces system level costs, and really gives you great outcomes.
Thanks, Dr. Beck. Okay, so most of what I heard there covered cost savings. Do either of you have any other strategies for cost savings, or perhaps even ways that we could increase reimbursement?
I can speak to that, John. So in addition to my pharmacy work, I've done a fair amount of work on clinical documentation. What the provider is documenting in the chart and how that affects the reimbursement to the facility. And what we found was we often saw providers documenting, but not in necessarily the way that would appropriately reflect the illness of the patient and therefore the reimbursement. And we also saw them neglecting some documentation that, while they didn't think it was necessarily clinically significant, it did have some utility in the reflection of level of illness. And so the way we did this is we approached each provider group, and we were able to build them discharge note templates. And within those templates were tools that would facilitate proper documentation for high value diagnoses that specific provider group would often see. So for cardiac thoracic surgery, they'd have a list of diagnoses that would be slightly different than oncology, for instance. But as a result of this approach, we saw, for instance, the neurosurgery group had an increase in annual reimbursement in the $400,000 to $500,000 range. That was controlled for severity of illness and volumes. Our general surgery service saw a $1 million annual increase year over year. And then our hospitalist program actually saw a much more significant. They saw 4 to 5 million. Their volumes are much higher. We have 100 hospitalists in our group. It's Swedish, but it proved to be an area that was readily addressable, and more times than not, the providers were very amenable to participating, and it's been a success so far at our institution.
John Price, I would add a couple other examples. We know hospital systems are suffering from penalties from the government, often for things like different episodes of care or readmissions. And so you can start to take the data from your own system about those particular items and look back to what tools that you have available or what workflows and processes that you can build on, including things like care coordination, handoffs to primary care within your system, and again, using electronic tools, some electronic monitoring, risk scores that you can build out within your system. These all give you visual indicators to workflows and operational solutions that really will help reduce those penalties and therefore have more money in your health system as well.
Awesome. So I know we're close to time here, and I really wanted to take a chance to kind of summarize what I heard here today. It sounds like there's a lot of major opportunities out there for cost savings through improved utilization of things like pharmaceuticals, labs, and procedures. And there's also some room for improvement on reimbursements through enhanced documentation strategies and risk stratification. So if you'd like to learn more about what Bluetree can do to help you in these areas, or if you'd just like to talk through it a little bit more, feel free to reach out to us and our client services team at clientservice@bluetreenetwork.com. I'd like to thank all of you for joining us today, and I'd especially like to thank Dr. Corson and Dr. Beck for taking their time to share their expertise with us today. Thanks, guys.
Thanks for having me, John.
Thank you very much.